Hello, I'm Dr. Gia Tyson, and welcome to the 1-hour hepatitis C provider training. I'm the clinical network specialist for the Louisiana Department of Health's initiative to eliminate hepatitis C in our state. I'm also a transplant hepatologist with Ochsner, as well as a clinical assistant professor of medicine with Louisiana State University. And we hope at the end of this training, you will be proficient and confident in your ability to treat hepatitis C. Remember, this is just a resource for you, but by no means a recommendation of how you have to practice medicine. We have a lot to get through in this training, so let's get started. First, I want to say there are no conflicts of interest or disclosures to report of anyone involved in the creation of this content. As far as our agenda, we'll talk about hepatitis C, the basics, authorized generic Epclusa, which is a combination of sofosbuvir and velpatasvir. We'll go through the evaluation and management algorithms. We'll discuss harm reduction, the provider network, and then finish with resources, surveys, and contacts. So let's start with hepatitis C, the basics. Hepatitis C is an RNA virus that does not incorporate into our genome. Because it doesn't incorporate into our genome, that means we can actually get it cured. So when you're treated for hepatitis C and cured, the virus is completely gone. Traditionally, we thought about 6 genotypes of hepatitis C. There's 1A, 1B, and then genotypes 2, 3, 4, 5, and 6. Genotype 1 is the most common in the United States. We used to think about this because it was relevant as it related to treatment. But now we have pan-genotypic regimens, which means they cover all genotypes. So this is becoming less important, but it's just something for you to be aware of. When we think about the risk factors of hepatitis C, we classically think of injection drug use, also blood transfusions, especially prior to 1992, when we really weren't checking the blood supply for hepatitis C. We think about risk factors of HIV that also put you at risk for hepatitis C. And then often underappreciated is that there's an increased risk of hepatitis C in dialysis patients. Tattoos, especially in unregulated environments, can also be a risk for hepatitis C. And lastly, sex. We don't often think of hepatitis C as a sexually transmitted disease because when you're in a heterosexual relationship, especially with a monogamous partner, there's really no recommendation for barrier methods because it's very low risk of transmission. When we think about men who have sex with men or other high-risk sexual practices in terms of multiple sexual partners, that's when the risk of hepatitis C becomes highest with sex. There's an additional risk factor that we also think about, and that came from the CDC, where there was a recommendation to really identify and screen for hepatitis C in baby boomers, those born between 1945 and 1965. This came about because with the traditional risk factors that we just talked about, we felt there were a lot of people out there that were not being appropriately screened and diagnosed for hepatitis C. And so once they looked at the baby boomer population, they realized that this group was disproportionately affected with hepatitis C. And so now the recommendation is that anyone born between 1945 and 1965 have at least one time screening for hepatitis C. When we think about screening, we think about hep C antibody testing. That's how you want to screen. If the antibody test is non-reactive, then for the most part, you're done. Unless you think someone has a very recent exposure or you're worried that maybe they can't mount an antibody response, but those are very unusual situations. So for the most part, we check a hep C antibody. If that's negative, then the person does not have hepatitis C infection. If the hepatitis C antibody is positive or reactive, then you need to do confirmatory testing. So I just want to repeat that. The antibody is only a screening test. So you must do confirmatory testing to determine if someone is actually chronically infected with hepatitis C. You want to do confirmatory testing with some type of RNA test, either quantitative or qualitative. So if the RNA quant or qualitative test is not detected, then usually you're pretty much done there. That person may have been exposed, but does not have active hepatitis C virus. If the hep C RNA is positive or detected, then that person is thought to have chronic active hepatitis C. And our hope is that they will be linked to a cure. When we think about hepatitis C, it's important to remember that it's not just an infectious disease, but it's in fact a liver disease, meaning that chronic inflammation can lead to scarring and fibrosis of the liver, and that can ultimately lead to cirrhosis, end-stage liver disease, and hepatocellular carcinoma. So even though our desire is to eliminate hepatitis C from the state, we don't want to forget about staging and the importance of determining if the person has significant or advanced liver disease, because they could be at risk for decompensation if they have cirrhosis in the form of ascites, encephalopathy, gastrointestinal bleeding, jaundice, and hepatocellular carcinoma. When we look at the natural history of hepatitis C, For the most part, people do get some level of an acute infection. The problem is they don't often have symptoms when they're acutely infected. Less than 1% of people will actually go on to have acute liver failure or fulminant hepatitis because of hepatitis C. And then we think about 15 to 46% of people will actually spontaneously clear the hepatitis C on their own. But the majority of people will go on to be chronically infected. Anywhere from 54 to 86% will develop chronic hepatitis C infection. Of those chronically infected, we think around 15, if not actually closer to 50%, will develop cirrhosis of the liver. And those with cirrhosis, we worry about 5% or 1 to 5% will develop hepatocellular carcinoma, and about 3 to 6% will develop hepatic decompensation. For ease, I just say 5% of people with cirrhosis on a yearly basis will develop HCC or develop liver decompensation. And then there's an annual mortality rate of around 2 to 4%. In those who are chronically infected with hepatitis C. It's also important to remember that people that have hepatitis C alone, even in the absence of cirrhosis, can develop hepatocellular carcinoma at a rate of 0.8% per year, but that rate is very low, which is why we do not screen for hepatocellular carcinoma in people who have hepatitis C alone, and we only screen in those who have cirrhosis. It's also important to remember that the lifespan of those with hepatitis C is usually at least 20 years shorter than those without hepatitis C, and that can be separate from having cirrhosis of the liver, which means that this is a virus that is quite deadly and very important for us to cure. So now we're going to turn to discussing the authorized generic Epclusa, which is the medication that you can use through the state's initiative without a prior authorization. You only need to know that the person has hepatitis C. And again, there are no longer requirements for abstinence with alcohol or illicit drug use. So authorized generic Epclusa is a combination of sofosbuvir and valpadisvir. It's a directly acting antiviral, or a DAA. These are the new classes of hepatitis C medications because they directly target machinery that the hepatitis C virus needs to replicate. So it's used for treatment in adults with chronic hepatitis C, genotypes 1 through 6, non-cirrhotic, compensated cirrhotics, treatment-experienced, and treatment-naive patients. It can also be used in decompensated cirrhotic patients, but this requires the addition of ribavirin. And for the purpose of the state's initiative, we're really not suggesting that primary providers treat decompensated patients. Now I want to point out that there's no renal function limitation. It used to be that you could not use sofosbuvir-based products if the creatinine clearance or GFR was less than 30, but that has changed. You can now use sofosbuvir-based products in all levels of renal dysfunction, including end-stage renal disease and patients who are on hemodialysis. So just to recap, generic Epclusa is pan-genotypic, covering genotypes 1 through 6. It's pan-fibrotic, covering levels of fibrosis from 0, 1, 2, 3, and 4. It can be used in treatment-experienced and treatment-naive patients. We will further define treatment-experienced patients later in this presentation. And then you can use it for any level of renal function. When we talk about treatment experience, we're really talking about people who receive the old category of treatments, not the directly acting antivirals. So if a patient had been treated before with pegylated interferon, which would have been shots that they gave themselves either 3 times a week or once a week, and then ribavirin-based regimens, or even those with the protease inhibitor who received interferon-based therapy, then you can definitely use generic Epclusa. But if they failed therapy with these all-oral regimens, such as Harvoni, Mavyret, and Zepatier, then you cannot use generic Epclusa. So if they were only on an all-oral regimen, you cannot treat that treatment-experienced patient with generic Epclusa. When we talk about the medication, it's fairly simple. It's 1 pill you take a day for 12 weeks, with or without food. It's that simple, and that's how I describe it to patients. 1 pill a day, with or without food, for 12 weeks. Don't miss a dose, and you're likely to get cured. There are very manageable drug-to-drug interactions and a very manageable side effect profile. We've also talked about the fact that there's no renal adjustment. So patients can take the medication once a day in the morning if they want, once a day in the evening, as long as it's at the same time every day. When we think about efficacy, cure is defined as a sustained virologic response 12 weeks after treatment. We call that SVR12. So someone is treated, they finish treatment, then you wait 12 weeks to check for SVR12. There's about a 98% SVR12 rate from all the combined clinical trials. That's fabulous. So 98% of people will get cured when treated with generic Epclusa. And the side effect profile is great. So people may have headache, fatigue, insomnia, nausea, or diarrhea. And again, only about 1 in 5 people will even have symptoms, and if they have them, the symptoms tend to be mild. And I always tell patients, you may have a little bit of a headache, you may feel tired, you may have some trouble sleeping at night, and then less commonly are the upper and lower GI side effects, which are nausea and diarrhea. Discontinuation due to these side effects, at least from the trial data, was only about 0.2%. So for the most part, when people get the side effects, they can continue to stay on therapy. Now, there is a black box warning that's very important to recognize. There is a risk of hepatitis B reactivation in patients with hepatitis B, hepatitis C co-infection, previous hepatitis B exposure, and those on immunosuppression. And we'll talk about how you determine this risk of reactivation later in the talk. There are drug interactions, very few, but there are some that we need to go over. So let's go through this list. Amiodarone. When sulfosphoride-based products are coupled with amiodarone, that can result in severe bradycardia. So there's no contraindication in the sense that you can use the two products together, but it does require cardiac monitoring. Most people think you need at least 48 hours of cardiac monitoring, and then after that, still some level of monitoring for severe bradycardia. So my recommendation is really that you try not to use them together, and if you are, you need to do it in conjunction with a cardiologist, a more experienced treater, and most likely a pharmacist. And remember, amiodarone has a very long half-life, so you can't just stop the medication and then start Epclusa the next day. So you really want to do this carefully in conjunction with a pharmacist. Digoxin. So it's another antiarrhythmic that has an issue with sulfosphoride-based products because it can cause an elevation of digoxin levels. So there's no contraindication, so you can use the two together, and there's no recommendation for or against using them together, but you do want to make sure that you monitor digoxin levels. And if you are going to stop someone's digoxin, you want to make sure that you do that in consultation with a cardiologist. So this is a big issue, the proton pump inhibitors. As a gastroenterologist, all of my patients are on PPIs, and probably as a primary provider, so are yours. So the question is, what do you do? The problem is when you use these in combination with generic Epclusa, it decreases the efficacy of the medication. So although it's not necessarily contraindicated, I'll talk about what you have to do if you want to use them together and which medication you can use. But again, it's not recommended that you use them together. So you can ask the patient to hold their PPI for 12 weeks, and some people will be okay with that. If your patient has very severe heartburn, then you can try to switch them to an H2 blocker, such as Pepcid. And what they have to do in that case is they would have to take the H2 blocker either at the same time as they take their generic Epclusa or 12 hours apart. So again, they can take the H2 blocker either at the same time as the generic Epclusa, or they have to separate it by 12 hours. It's also important to remember that some people are on antacids, so if they're taking any Tums, Maalox, or other antacids, they have to be separated from generic Epclusa by 4 hours. Now, if your patient absolutely has to be on a PPI, you can do it, but it has to be omeprazole at the lowest dose, which is 20 milligrams. And now they have to separate the generic Epclusa from the omeprazole by 4 hours, so that becomes a little bit more complicated. I must say I've never had to do that yet. I usually do use one of these other options that I've already mentioned. But if you have to do it, maybe the easiest way to remember it is to have someone go ahead and eat their breakfast, or whatever they eat as their first meal, because they have to take the generic Epclusa now with food. Remember, for the most part, generic Epclusa is used with or without food. But when you're going to add a PPI, you have to take the generic Epclusa with food. So I say take the generic Epclusa with whatever they eat in the morning, and then for their next meal, you can recommend that they take their PPI. For most patients, that's a lot to remember, so you really should try one of the other options, or if they really have to be on a PPI at high dose or another PPI besides omeprazole, then you want to actually consider using another medication besides the authorized generic of Epclusa. And this is a nice time to remind you that with the state's program, even though you can use authorized generic without a prior authorization, it doesn't mean that you can't use some of the other medications. You can, but you will just have to give an explanation of why you cannot use the authorized generic of Epclusa. So the statins, that's another big category of medications that some of your patients will be on that will have some drug-drug interaction with generic Epclusa. It can increase the risk of myopathy because the concentration of the statin is increased. So there's not a contraindication, but you have to be careful when you use these two medications together. So if possible, if someone is usually only using these medications in terms of the statins for prevention or low risk in terms of their coronary artery disease profile, you may want to just hold the medication for 12 weeks. You can decide if you feel comfortable holding it on your own or if you want to consult with the patient's cardiologist. Otherwise, you can consider changing them to pravastatin because pravastatin at any dose is safe with generic Epclusa. Or you can use the minimal dose. So for rosuvastatin or Crestor, the minimum dose would be 10 milligrams a day. For atorvastatin or Lipitor, there's actually no recommended minimum. It just says that you have to monitor for potential side effects. My personal strategy is I will usually let people go up to anywhere from 20 to 40 milligrams of atorvastatin or Lipitor a day. And again, I always advise them to look for muscle aches, myopathies, anything, arthralgias, anything that they may confuse for myopathies to make sure they're not having side effects from the drug-drug interaction. In terms of HIV Hep C co-infection, there are really not a lot of drug interactions. The biggest one I want to point out is with efavirenz. It can decrease the concentration and efficacy of the Epclusa, so this is a contraindication, and so you really want to make any changes to someone's HIV medication regimen in conjunction with their ID doctor or their HIV doctor. Other medications like St. John's worts, rifampin, carbamazepine, phenytoin, phenobarbital, these are medications that commonly have drug-to-drug interactions with most other medications because they can decrease the efficacy of those medications. So you want to try to hold them if possible. I'll point out that when it comes to the anti-epileptics, they can also be used as antipsychotics or mood stabilizers. So you don't want to change these medications without consultation from the patient's neurologist or psychiatrist. These are the major drug-drug interactions, but if you'll notice from this list, for the most part, generic Epclusa is very safe to use. The biggest interactions that I usually have to look for in my patients have to do with PPIs or acid-suppressing medications, and then the statins or the lipid-lowering medications. So now that we've covered the basics, let's go over the streamlined algorithm. This is the algorithm that we've come up with to hopefully make it easier for you to provide treatment to your patients. We've come up with a streamlined test and treat algorithm that is in one format on one page that covers just about everything that you need to know. So typically, we're talking about adults. Currently, generic Epclusa is not approved for pediatrics, and so we recommend that you do your standard history and physical. You're going to get your standard labs. The labs will typically include a CMP, a CBC, HIV, hepatitis B surface antigen, hepatitis B core antibody total, hepatitis B surface antibody, hepatitis A IgG, and in those who are of childbearing age, a urine pregnancy test. You'll note that no genotype is required because this medication is pan-genotypic. We no longer require genotype testing, and that can be quite expensive for the state. We also want you to know who you should not be treating. So we think you should send someone to a specialist if they have prior DAA use, like we discussed before. If they're co-infected with Hep C and HIV, we recommend they be referred to a more experienced treater. And if they're Hep B and Hep C co-infected, we also recommend they be referred to an experienced treater or a specialist. If they're pregnant, because these medications are not currently approved in pregnancy. And then if someone has decompensated cirrhosis, and we'll discuss what that means more by Child-Pugh scoring, if they're Child B or C, or if they have a MELD score of greater than or equal to 15. So we'll go more into this streamlined algorithm. So we're recommending that everyone get transient elastography, and we'll talk more about that. That's basically a method for staging to determine if someone has no fibrosis of the liver, if they have stage 1, stage 2, stage 3, or stage 4 fibrosis. And we have certain cutoffs. So if the kilopascal cutoff on the transient elastography, or commonly referred to as FibroScan, is less than 12.5, then you can go down the no cirrhosis pathway. If the kilopascal cutoff is greater than 12.5, we want you to consider that person as having cirrhosis and go down the cirrhosis pathway. If you don't have transient elastography available, no worries. You can still move forward. You can use the APRI score and the FIB-4 score. We're recommending that you use both. So you should calculate both the APRI and the FIB-4. We'll talk about these more in a second. If the APRI score is less than 2 and the FIB-4 score is less than 3.25, then you can go down the no cirrhosis pathway. If the APRI score is greater than or equal to 2, or the FIB-4 score is greater than or equal to 3.25, then you need to go down the cirrhosis pathway. So if you're going down the no cirrhosis pathway, no HCC screening is needed. You can proceed with treatment with generic Epclusa and then check for SVR12. After that, congratulations, the patient is cured, you're happy, they're happy, you're pretty much done. Now, if the person is cirrhotic, you do have to do screening for HCC. We are recommending an ultrasound with AFP, which is the alpha-fetoprotein or the tumor marker for hepatocellular carcinoma. If that's negative and the person does not have HCC, or you don't have an ultrasound available yet, you still can proceed with treatment with generic Epclusa, and then you will have to check for SVR labs, but that person will require post-treatment HCC surveillance and referral to a specialist for continued monitoring. Now, if you do discover a lesion or the AFP is significantly high, and if that person has been diagnosed with HCC, then prior to treatment, you do need to refer that patient to a specialist. Let's talk about staging. This is very important because, as I previously discussed, hepatitis C is not just an infectious disease, but it's a liver disease. And so you can have no fibrosis of the liver, which is F0, or you can have F1, F2, F3, and F4. So we talk about staging based on centering around the portal tract, which is the portal vein, the hepatic artery, as well as the bile duct. So if there's a little bit of fibrosis around the portal tract, that's considered F1. If those fibrous bands start to extend towards another portal tract, that's considered F2. If those fibrous bands go from one portal tract to another portal tract, which is called bridging fibrosis, then that's F3. If we see that those fibrous bands go from one portal tract to the next, then to the central vein, and cause a nodular formation, then that's considered F4 or cirrhosis of the liver. You can determine cirrhosis clinically if someone has ascites, jaundice, or spider angioma or telangiectasias. That may be clinical indications that they have cirrhosis. But not everyone with cirrhosis will have these clinical findings. Sometimes you have to look at the lab work, and the lab work can tell you. So what I consider the poor man's test for cirrhosis is when the AST becomes higher than the ALT, so slightly greater than a 1-to-1 ratio, or if someone has a low albumin, thrombocytopenia, or elevated bilirubin. FibroScan is another great test for determining cirrhosis and staging liver disease, which is what we are recommending as part of the state's initiative. But if you don't have access to a FibroScan, it is okay to use the APRI score, FIB-4 score, or you can get a FibroSure test, which we'll discuss later. Now, liver biopsy is still the gold standard for determining liver fibrosis, but we rarely need that these days in a time when we can get other measures for liver fibrosis. So FibroScan. So FibroScan is a proprietary test performed and owned by EchoSense, and it's an operating principle of using vibration-controlled transient elastography. This is an example of a FibroScan machine. This is one that's very portable, but most of them are fairly compact, and you can usually have them in your clinic, or sometimes they have them in radiology offices. FibroScan is also known as transient elastography, and this is what we're using to determine liver fibrosis. It's in shear waves followed by ultrasound waves to measure liver stiffness. The faster those waves move through the liver, the more firm the liver is and the more fibrosis there is. So if you look at these pictures, a healthy liver has a nice slope, whereas a cirrhotic liver has a steeper slope. So we're preferring that you use FibroScan as a method of staging, but this is not required. We highly recommend that you get staging done prior to starting treatment, as this should be used to determine follow-up. And then even though staging does not have to be done prior to treatment, we are really recommending it. And if you don't want to stage before treatment, it's just important to know that it should be done at some point while the person's on treatment. Obviously, our goal is complete eradication, so we don't want this to limit you in getting people treated, but it's important to remember that it needs to be done. Also, the kilopascal cutoff is greater than or equal to 12.5, which is consistent with stage 4 fibrosis or cirrhosis of the liver. So if someone has a FibroScan that shows a kilopascal cutoff of greater than or equal to 12.5, you want to make sure you're going down the cirrhosis pathway. And then what was a surprise to me is that the FibroScan is actually cheaper than the FibroSure, which is a test that we were commonly using as a lab test to determine staging. If you do not have access to a FibroScan, you can get on a computer and calculate the APRI and FIB-4 scores. The APRI, or the AST to platelet ratio index, can be calculated by taking the patient's AST divided by the upper limit of normal for the AST value, which is typically 40. And then you divide that number by the platelet count, multiply by 100, and that will give you a score. For the purposes of this program, we are using an APRI score cutoff of greater than or equal to 2 to suggest that someone has cirrhosis. We also want you to do the FIB-4 calculator. That takes into account the patient's age, platelet count, AST, as well as ALT, and will give you a score. And a score of greater than or equal to 3.25 should be considered as consistent with cirrhosis. So you want to do both scores. That's very important, because if either one is above our threshold, you need to consider that person as having cirrhosis. And the reason why it's important is because if you look at this example, when I look at the APRI score for this patient, to me, this is a patient who's cirrhotic because the AST probably is higher than the ALT and the platelet count is low. So even separate from doing the calculator, I'm worried this patient has cirrhosis. Yet according to our algorithm, this score is only 1.8, which is less than 2.0, and the patient would not be cirrhotic. But if you put that same patient's information into the FIB-4 calculator, you would get a high FIB-4 score, greater than 3.25. And so therefore, because one of the scores is above our cutoff, you would have to consider that patient as having cirrhosis. So this is a prime example of why you need to make sure that you use both calculators. Let's talk about the FiberSure test. This is a proprietary test that uses bilirubin, haptoglobin, GGT, alpha-2 macroglobulin, and apolipoprotein A, age, and sex to give you a level of fibrosis. So it's basically lab testing that you send off, and it gives you back an answer. For the purposes of our program, you can use the cutoffs that are given to you when you get the report back. So it'll tell you if they're F0, F1, F2, F3, and F4. Again, this is an option for staging, but not the preferred one. We prefer to use FibroScan, and then after that, using the APRI or FIB-4. And those are perfectly acceptable means of staging. A lot of people are used to the FiberSure, so you can send that, but it's not required. It's very important that we also talk about compensated and decompensated cirrhosis. So we've talked about how you stage disease, but there will be some of those patients that when you do your staging, they will be cirrhotic. And the next question will be, are they compensated or decompensated? And that's important to answer. So they may be obviously decompensated if they have ascites, variceal bleeding, hepatic encephalopathy, or jaundice, but it could be more subtle than that. And so to determine the subtle nature of decompensation, it's important to calculate the Chiles-Pugh score. So the Chiles-Pugh score uses both objective and subjective criteria to let you know if someone has decompensated cirrhosis. What's included in the Chiles-Pugh score is encephalopathy, ascites, albumin, bilirubin, as well as the prothrombin time. Again, you can find this on any computer, and you can put in the numbers to give you the score. For the purposes of our program, we are saying that someone is compensated if they have Class A Chiles-Pugh score, but if they're Class B or C, you should consider that person as decompensated, and those individuals need to be referred on to more specialty care prior to being treated. Another important factor to take into consideration is the MELD score. That's the Model for End-Stage Liver Disease score, MELD. The MELD score goes from 6 being normal to 40 being very abnormal. When the MELD score gets to 15, that's when we think the benefits of transplant outweigh the risk. So we are really want you to focus on calculating this MELD score in addition to the other calculators. The MELD score includes the bilirubin, the INR, the creatinine. You have to say whether or not someone is on dialysis, the sodium, and then that will give you a score. When you get that score, it's designed to tell you the 3-month mortality of that person with cirrhosis. If you look at the scoring system, a MELD score of 9 or less is a relatively low mortality of 1.9% in 90 days. Then between 10 and 19 is a 6.0 mortality in 90 days. A MELD score of 20 to 29 is a 19.6% mortality within 90 days. And a MELD score of 30 to 39, which is getting quite high, is a 52.6% mortality in 90 days. And a 40 score is a 71.3% mortality within 90 days. So this helps you to understand how that score is used, but for the purposes of this program, we want you to know that 15 is the magic number. Because that's the number that transplant needs to be considered, we are recommending that if someone has a MELD score of 15 or greater, that they be referred to a specialist prior to initiating treatment, because that person may really benefit from a transplant over hepatitis C treatment. So that's the streamlined test and treat algorithm. That covers the basics of what you need to know. So for the rest of the talk and the rest of the algorithms, we'll focus specifically on more details in terms of pre-treatment, on-treatment, and post-treatment management. Pre-treatment should be fairly easy because it pretty much covers everything that I've gone into detail with the overall streamlined test and treat algorithm. So for pre-treatment, of course, you want to make sure that you confirm that someone has hepatitis C infection. Remember, there are no restrictions as it relates to alcohol use or fibrosis staging. It used to be that you could only get treated through Medicaid if you had stage 3 or 4 fibrosis, but now you can get treated if you have stage 0, 1, 2, 3, or 4 fibrosis. You want to do your baseline history, physical, and lab testing, the labs which we've already discussed. You want to make sure that you're doing the appropriate staging, which is by FibroScan, FiberSure, APRI, or the FIB4 testing. And then you want to remember that if someone has evidence of decompensated cirrhosis, you want to refer that individual to a gastroenterologist or hepatologist. And if the MEL score is greater than or equal to 15, those individuals also need to be referred on to a more specialized provider. If someone has HIV co-infection, they need to be referred to an infectious disease doctor or a more experienced treater. If they're Hep B co-infected, they need to be referred to an infectious disease doctor or a GI specialist. And then if someone is pregnant or pediatric, we're recommending referral to a more experienced treater because currently there's no treatment approved for that population. And if someone has previous DAA use, then you want to refer those on to a more experienced treater. It is important to remember that as part of your staging, if someone is cirrhotic, you need to screen for HCC. And if you find a lesion, they need to be referred on to a specialist. If they're decompensated, refer them to a specialist. And then if they're cirrhotic and you are going to treat them for their hepatitis C, you need to make sure that you're doing the regular HCC surveillance, which is an ultrasound with AFP testing every 6 months. We have a little box here also to give you a hint of when someone may be cirrhotic, things that you may want to consider like the bilirubin, platelet count, imaging characteristics that suggest cirrhosis, ascites, the FibroScan, APRI, FIB4, and FiberSure cutoffs are also here for your perusal. And then we don't want to forget about prevention. Prevention is key. So if someone has hepatitis C, you want to make sure that you figure out if they've been immune or exposed to hepatitis A and hepatitis B. If they do not have hepatitis C antibody positive or hepatitis B antibody positive, you want to make sure you get those people vaccinated for hepatitis A and hepatitis B. So this is a part that people don't like a lot, and that's the hepatitis B assessment. So take a deep breath and make sure you're really focused for this part of the talk, because it's important, because it's a black box warning. So what's circled in red are the tests that you really need to check, but we're going to go through all of them just so that you're familiar with the hepatitis B testing. So there's hepatitis B surface antigen, there's hepatitis B core IgM, hepatitis B core IgG, hepatitis B surface antibody, and then there's hepatitis B DNA. In acute infection with hepatitis B, you expect the surface antigen to be positive. You expect the hepatitis B core IgM to be positive because IgM antibodies are suggestive of acute infection. And you expect the hepatitis B DNA to be positive because the person is actively infected. In chronic infection, which is usually separated by 6 months apart of identifying these labs, you expect the hepatitis B surface antigen to be positive because they're infected. No longer do they have IgM positive because now they've seroconverted their hepatitis B core IgM to a hepatitis B core IgG being positive. Then the hepatitis B DNA is positive because they're actively infected. When someone has natural immunity, meaning that they were exposed to hepatitis B before, but they cleared the virus on their own, that individual will have hepatitis B core IgG positive, but they will also be protected with the hepatitis B surface antibody. When we look at vaccination, that individual will only have hepatitis B surface antibody positive. Because in order to have core antibody positive, you had to have actually been exposed to the virus itself previously. So for those who are only vaccinated, they have hepatitis B surface antibody positive alone. Then there's also this window period. I put this here just for your perusal. It's mostly a test question, so it's not so relevant for your management of patients with hepatitis C, but important to know about because this is what we hear about often. So remember, the only labs that you really need for determining someone's hepatitis B status as you're going to start treatment is the hepatitis B surface antigen, the hepatitis B core IgG, and the hepatitis B surface antibody. This is a reminder about who you can treat. That's treatment experience. Again, if they fail treatment with interferon-based therapies, that's okay. But if they fail treatment with the DAAs like Harvoni, Mavyret, or Zepatier, then you cannot use generic Epclusa to retreat that patient. So anyone who received treatment with all oral regimens cannot be retreated with generic Epclusa. The role of ultrasound. We've mentioned it here and there, but not in a formal way. And that's because an ultrasound is not required. Now again, as a hepatologist, that gives me a little bit of anxiety. But I realize from a population perspective, it's probably not needed. So we do recommend getting an ultrasound if someone has abnormal liver tests, because in my opinion, that is part of the evaluation of abnormal LFTs. But if someone has normal liver tests and has hepatitis C, then you don't necessarily have to get an ultrasound. Now, if someone is cirrhotic, as we mentioned before, you do need to do HCC surveillance. And we recommend that you get an ultrasound with AFP every 6 months for HCC surveillance, and that's very important. Let's talk about prevention. Even though we're not requiring cessation from alcohol and illicit drug use, it is important to address these when you're discussing with patients about hepatitis C treatment. Ideally, we prefer alcohol avoidance while on therapy, and certainly alcohol avoidance after completing hepatitis C treatment. But if people cannot avoid alcohol, you want to talk about reducing the amount that they take, because alcohol can still result in progressive liver disease with continued use. We also want to evaluate for other causes of liver disease like fatty liver. So if you know that a patient is at high risk for fatty liver disease, you want to discuss weight management plus glycemic and lipid control. We've already discussed the importance of vaccinations. So if someone is not immune, you want to make sure they get the vaccination series for hepatitis A and or B if needed. And then lastly, we want to do some type of evaluation and management for continued substance use. There is a risk of reinfection with hepatitis C even once someone is cured. Evaluation and management for substance use is also very important, because if they have continued illicit drug use, they can be reinfected with hepatitis C. So you want to make sure you offer these individuals harm reduction services. Just a reminder, I know we've talked about it multiple times, but we want to make sure you feel comfortable. Certainly we want you treating people for their hepatitis C, but if something feels out of your comfort zone, have a low threshold to refer them to a specialist. If they have Hep B, HIV, pediatrics, pregnant women, decompensated cirrhotics, prior DAA use, and also medication considerations. Again, if you feel comfortable with the drug interactions, you can still treat the patient yourself. But if you don't feel comfortable managing amiodarone or anti-epileptics and the hepatitis C medications, then you want to see about sending those patients to a specialist. So that ends the pre-treatment algorithm. That was the hard part. The easy part is really once you get someone on treatment because the medication is so well tolerated. Now we'll discuss the on-treatment algorithm. If someone is protected against hepatitis B, so they have the hepatitis B surface antibody positive, either through natural immunity or vaccination, then they're at low risk of hepatitis B reactivation, and there's really no on-treatment monitoring that's needed. But if somebody is isolated hepatitis B core antibody positive, then you need to check a hepatitis B DNA, because the concern is that they could reactivate because they do not have surface antibody positivity. So when you check the hepatitis B DNA, if it's positive, then they're considered co-infected, and those individuals should be referred to a specialist. If the hepatitis B DNA is negative, then those are the individuals that will require some on-treatment monitoring. And we're recommending that you check a hepatic function test 4 weeks after starting therapy. And you can just check a hepatic function. For those individuals who have never been exposed to hepatitis B and are not immune, then those individuals are at low risk of reactivation. So you do not have to do any on-treatment monitoring, but you do want to make sure you get those individuals vaccinated. So for lab monitoring, what we're talking about is someone who has isolated hepatitis B core IgG positivity. These individuals are most likely exposed to hepatitis B and cleared the virus on their own. It's possible they have low-level antibody positivity, and if they were exposed to hepatitis B, would mount antibody reaction. But because we're not sure, we are recommending that you check a hepatitis B DNA, one, to make sure there's not a occult infection, but if that hepatitis B DNA is negative, then you do want to proceed with vaccinating those individuals to make sure that they are truly protected against hepatitis B. And as well, if they're isolated core hepatitis B positivity, then you want to make sure you check a hepatic function anywhere from 4 to 6 weeks after starting hepatitis C treatment. If the labs are normal after being checked, then usually you don't have any worries about hepatitis B reactivation. But if the labs are abnormal or you're worried they're increased from baseline, then you want to definitely check a hepatitis B DNA because that person could have hepatitis B reactivation. And at the same time, you want to make sure that you're calling your specialist to get any added assistance that you may need. We don't want to forget about pharmacy and case management. They can be very important while someone is on treatment. So consider using a pharmacist and a case manager to provide patient support. They can provide education at the start of treatment. They can also make sure that patients know when their refills are due, and they can also follow up on post-treatment care. Specialty pharmacies can be particularly helpful because they have a charge to educate patients. So they can help you with education prior to treatment. They can help you with drug-drug interactions, make sure that people are compliant while on therapy, as well as follow-up that may be needed at a later time. So don't forget your pharmacist and your case managers. But if you don't have those, no worries. The hope is that you'll see that for the most part, this is fairly easy to incorporate into your practice. That's the on-treatment algorithm. For the post-treatment algorithm, it's very simple. You want to decide if someone has cirrhosis or not. So if they're not cirrhotic, so they're stage 0, 1, 2, 3, or 4, then you want to check SVR12 labs. So after they've been off therapy for 12 weeks, you want to check a hepatitis C viral load as well as hepatic function. If they have cirrhosis, you're going to do the same thing. You're going to check SVR12 labs, which is checking a hepatitis C viral load as well as a hepatic function. If they are non-cirrhotic, you want to make sure that the viral load is negative and the liver tests are normal. If the viral load is negative and the liver tests are normal, again, congratulations, you're done. Your patient is happy, you're happy, no particular liver follow-up is needed. But if the hep C RNA is still positive or the liver tests are still abnormal, then you want to refer that person on to specialty care because they may need more treatment for their hepatitis C, or if the viral load is negative, but the liver tests are abnormal, they may have another liver disease like autoimmune hepatitis or fatty liver disease that requires more investigation and management by a specialist. If the person is cirrhotic and you check their SVR labs and hepatic function, even if they're cured, you want to make sure that you refer that individual on to more specialty care because they will need continued monitoring for HCC surveillance as well as for liver decompensation. Remember, SVR12 is a hep C viral load negative 12 weeks after treatment. At that point, we would consider the patient to be cured. For HCV elimination, we think it's important that you document cure, which is SVR12. This is a graphic representation of SVR. So someone's viral load is high at the beginning, and then you put them on treatment, and hopefully at the end of treatment, the viral load is undetectable. But you can't tell if someone is cured at that point. You have to wait 12 weeks. Then you check another viral load. If the person is virus negative after being off of treatment for 12 weeks, then you can consider them to be cured. Any SVR after 12 weeks is likely to result in cure, but we prefer you to really check for SVR12. You want to educate patients about their post-treatment monitoring as well. So the hepatitis C antibody will always be positive. That's very important to know because sometimes patients are referred back to me who think they still have hepatitis C because someone checked their hepatitis C antibody. If you want to determine reinfection, you really have to check a hepatitis C RNA. You really need to know that the virus is still in the blood. You also want to make sure you're reevaluating people who are at high risk of reinfection. So if someone is continuing to have high-risk behaviors or have illicit drug use, especially injection drug use, then you want to make sure that you're checking a hep C viral load yearly to determine reinfection. Otherwise, if someone is low risk of reinfection, especially like our baby boomer population, and you've cured their hep C, then no other hep C monitoring is really needed beyond the SVR12 labs. That's the post-treatment algorithm. Whew, so take a deep breath, because that was the most intense part of the learning. Those algorithms were designed to make sure that you can feel confident and prepared when evaluating, managing, and treating people with hep C. Now we're going to shift gears. We're going to talk about harm reduction, which is important because we know that around 75% of new cases of hepatitis C are among people who inject drugs. We have to know how to talk with people who have higher risk behaviors, and it starts with the philosophy. We want to acknowledge people's personal autonomy and encourage individuals to take ownership of their health. We want to establish relationships and rebuild trust in the healthcare systems. It's not a series of services, but an underpinning philosophy that should be applied to all care settings. We want to make sure that patients feel that they are respected, that they have dignity, that there's compassion, and that there's no judgment. So for harm reduction to work, we need to apply all of these principles. We want to make sure that we're meeting patients where they are and not where we think they should be. And of course, we want to make sure that we're offering options that are non-judgmental and non-coercive in terms of the services and resources we provide. We want to treat people, we want to provide them the services that they need without any expectations that they have to stop some of the behaviors that we may or may not agree with. And we want to be open and ask questions and really listen. Hear what people are saying and not just tell them what we want them to hear. There are a number of harm reduction services that can be very helpful. We won't go through them all because that's not the purpose of this talk, but it's important to recognize they're out there and that they're equally as important in treating someone who has high-risk behaviors to make sure that they don't get reinfected and that we can truly reach our goal of statewide elimination. There's syringe access programs, syringe disposal. There's a way to talk to people about safer drug use. There's naloxone therapy to help prevent mortality related to overdoses, medication-assisted treatment. There's supervised consumption services, drop-in centers, housing, pharmacy, and referrals. We can't take for granted that meeting people where they are often can lead them to the road of recovery. The provider network is very important, and so we want to make sure that our provider network has the resources they need to be effective treaters. We have 1-hour in-person sessions similar to the one that we're doing here recorded, and we have this recorded webinar that people can do on their own time. We also have a clinician warm line, which is a phone number that you can call, so if you have questions in real time, we can help by giving those answers. We have a Hep C Champions training that can be used for those people who really want to be high-volume treaters, as well as to get more in-depth information and knowledge around hepatitis C. We have physician detailers, Drs. Brandon Misrock, as well as Dr. Frederick McCall, and we'll be happy to assist you. You can also become a Hep C champion. If you want to become a Hep C champion, you have to attend the half-day CME conference. There's also a 12-part video conference series, and you have to attend 70% of them. At the end, there will be an exam you have to take. You have to pass that exam, and then you can get a certificate to be a hepatitis C champion. For the provider network, it is our hope that you will now feel confident and proficient in the ability to treat hepatitis C patients and get started with treatment. We want you also to help us identify providers who may be interested in training. We'd like you to sign up for our provider directory and join us for additional trainings so that you can keep up to date what's going on with hepatitis C. In this last section, we'll cover the resources, surveys, and contacts that can be of use to you. Here are some websites that you should be familiar with. There's Louisiana Health Hub, as well as Hep Cured LA. The Louisiana Health Hub has a lot of information about both hepatitis C as well as HIV. And now we have a new campaign for the elimination plan, and it's called Hep Cured LA. It has its own website. If you go to that website, you can find information about hepatitis C as well as the trainings that we offer. Make sure you spend time with each of those sites. There's a lot of great information there. We also have a post-training survey that we'd love for you to complete. It's very easy to access. Just pull out your camera and put your camera towards the QR code, and the survey will come up. This provides us with a lot of information to make sure that this session is maximized and optimized for your benefit. There's another QR code for our hepatitis C provider directory. We'd like to make sure we know who's out there doing hepatitis C treatment. So again, put your camera up to this code and it'll take you to where you can sign up to be a part of our hepatitis C directory. This concludes our 1-hour session. Thank you so much for your time and attention. We hope that you'll go out there and help us truly eliminate hepatitis C in the state of Louisiana. If you need anything, again, I'm Dr. Gia Tyson. You can contact me at the email provided here. You can also contact our physician detailers, Drs. Brandon Misrock, as well as Dr. Frederick McCall, and we'll be happy to assist you. Let's get to treating.